Hello, everyone. My name is Hung Bo, and I am one of the rheumatology fellows here at BUBMC. And thank you for the opportunity today to talk to you about an exciting project that I've been doing with the Division of Rheumatology, in particular with Dr. Andrea Ricciur, who's one of the principal investigators of this project, and is named Spatial Frequency Domain Imaging as a novel method to quantify skin changes in scleroderma. So what is scleroderma? So scleroderma is also known as systemic sclerosis is a quite rare autoimmune disease and is characterized by excessive collagen deposit into the skin, and it can cause skin thickening, but it can also deposit into the other internal organs. Skin fibrosis remains as one of the most common manifestations of this disease, and the accurate quantification of the skin fibrosis in scleroderma is very important to us because it can provide important clues about the severity of the disease as well as survival and response to therapy. So how do we evaluate skin fibrosis? So the gold standard for this is the modified Rodnan skin score. So the modified Rodnan skin score is a physical exam where the physician will pinch the skin in 17 different areas and give it a score from 0 to 3, with 0 being a normal skin with no thickening. 1 is when you have a little bit of skin thickening that can be detected between two fingers, and then 2 is moderate thickening, where it's difficult to make a skin fold and you're unable to appreciate the fine wrinkles. And 3 is severe thickening when you're unable to pinch the skin at all. Now, MRSS has been validated, well validated, and is correlate well with the skin biopsy. But because of how subjective these tests is, it does have its limitation, and it does have a significant intra-rater variability, where some of the study has cited that the reported ICC or the intra-class correlation coefficient could be between zero point 0.5 to zero point 0.8, depending on the study, and it does require adequate training to improve the score. And also, there's differences in the skin between different ethnic groups, and in minimal skin changes, it's very difficult to differentiate between a 0 and a 1. So because of this limitation, we do need a new method to kind of quantify in the skin fibrosis in a more objective and accurate way. And one of the way is through SFDI. So what is SFDI? So in a nutshell, SFDI uses light to measure the tissue properties. So in Figure A, it shows a simplified schematic diagram of an SFDI system where you have a light source from the projector, the illuminate light to an area of interest underneath. And the illuminate light can be at different wavelengths, ranging from 471 up to 851 nanometer, and it could be a different spatial frequency from 0.5 to 0.5 reciprocal millimeter. Because it used different patterns of light with different spatial frequency, that's why it had the name spatial frequency domain imaging. And then once the light reaches the tissue, then you can measure how much light was absorbed by the tissue, how much light scattered, or how much it reflects back within the tissue, and these get captured by the camera over here. And all of these measurements are quantifiable, and they are known as mu alpha for tissue absorbance, mu S prime for reduced scattering, and RD for diffuse reflectance. And in Figure B, you can see that because absorbance and reduced scattering can be measured at different wavelengths, we have to know which wavelength gives you the best separation between a patient with normal skin versus a scleroderma skin. And we found that both absorbance and reduced scattering can be affected by skin tone of the subject. And at 851, it seems like the mu S prime is less sensitive to skin tone, and it can be distinguished better from a patient with a normal skin versus scleroderma. As you can see that over here, you can see the separation nicely between the healthy control versus scleroderma patient, whereas in the absorbance, they can be very difficult to differentiate. And in the first figure, you can see clearly the difference between the two at the 851 nanometer range. And also in the last part, which you see, it does show that SFDI have a very good intra-class correlation coefficient, which ranging in the 0.8 to 0.9, which is excellent. So now we can discuss about some of the interesting results that we found in our studies. So the first one is Figure 1, where we compare reduced scattering of US prime between 8 healthy controls and 10 scleroderma patients. And in Figure A, we can see that the scleroderma patient showing significantly lower reduced scattering compared to the healthy control. And this makes sense because if light has to travel through a deeper tissue or thicker skin with more fibrosis or collagen, then most likely you will have less light scattering compared to a thinner skin or less fibrosis. But what more intriguing is that in figure B, when we compare healthy controls who technically have a MRSS score of 0, we score them with individuals with scleroderma who also have a skin score of 0, we can observe a statistically significant difference between the two groups. And this is exciting because it suggests that SFDI can enable us to identify early skin changes in scleroderma patients. In figure 2, we try to validate SFDI by evaluating the correlation between reduced scattering and diffuse reflectance with the MRSS. Now, the local MUS prime was calculated by summing the 6 measurement sites from left and right hands, fingers, and forearms, and then we plot against the local MRSS, which is the sum of the same 6 sites. And then we did the same thing for RD. Now, when we calculate the Spearman correlation coefficient, there was only a moderate correlation between local US prime with the MRSS with the correlation coefficient 0.57, which is only moderate. But when we compare between local RD and local MRSS, we found a stronger correlation with a coefficient of 0.77. Now, even though it's not as strong in local US prime, it did show that SFDI does correlate with MRSS. 3, we're trying to validate SFDI by comparing the SFDI measurements of the RD with the histological markers of fibrosis, which is alpha smooth muscle actin and trichrome. As you can see with the control patients, you can see they do not have much staining compared to the patient with scleroderma. And when we calculate the Spearman correlation coefficients, you can see that these numbers show that there's a strong correlation between SFDI and the histological markers of fibrosis. Lastly, we try to investigate SFDI's capacity in detecting longitudinal skin changes in scleroderma patients. And we did that by collecting longitudinal data in 6 of the scleroderma patients and 2 healthy control from the first cohort. And we, in figure 4a, we compare the longitudinal changes in the MUS prime and the MRSS for each of the subject by adding the MUS prime of the left and right forearm and plot it against the MRSS in the left and the right forearm at 2 different time points with T1 and T2, with the direction of the arrow indicate the progression of time, and the difference is 2 time points at least 2 months apart. And we can see that there's 3 scleroderma patients, 1, 2, and 6 with 4 points improvement in their MRSS score. Only 1 patient, which is scleroderma 3, only have 1 point improvement in the MRSS score, and 2 patients, 4 and 5, remain stable with no changes in their MRSS score. And when we compare, very similar to the control, the patient with no improvement in their MRSS have a very minimal changes in their MUS prime. When you compare that with the patient with improved MRSS, there's a proportional increase in light scattering for MUS prime. Now, in figure 4b, we're trying to investigate the correlation between the changes in the US prime with the changes in the forearm MRSS. And when we plot it and calculate with the Spearman test, we do see that there's a strong correlation, which with a coefficient correlation of 0.74. Now, this means that if there's when the skin condition of the scattered patient improves, there's a strong proportional increase in the tissue scattering. And these show that SFDI can be used to detect longitudinal skin changes in scleroderma patients. From all the presented data, we do believe that SFDI is a promising tool in providing quantitative and objective measurements of skin fibrosis in scleroderma patients. In particular, SFDI can differentiate early skin changes, which is great. It does have a significant correlation with both MRSS and histology scores. And lastly, it can also provide longitudinal skin changes data in scleroderma patients, which is great in clinical practice as well as clinical trials. For future works, we would like to enroll more patients in our study and would like to refine our protocol so that we can increase the sensitivities for assessing skin changes, not only in the forearms, but also in the arms, the hands, and the fingers, and would like to create a portable device for so that we can distribute it. It's easier to different centers. And I also like to acknowledge our funding sources. Thank you very much for the opportunity, and I hope that you enjoyed the presentation.